try and use tissues, throw them away, cough on your arm, and wash your hands. I can't say this often enough.
So did you know that 90% of unvaccinated contacts will get infected? And so I think people, worry about the acute phase, but it's the long-term impact that's really devastating.
So I think the key point here is what you said earlier, is take a good history, make sure you've identified them, and then get advice from your paediatric infectious disease team or the HPSA.
Yeah.
Liz, it's very nice to see you again. Who knew that I would see you so soon? So my name's Emma Lim, and I'm a consultant paediatrician at the Great North Children's Hospital, and we're here on the Paeds round talking to Liz Whittaker from London, who we've actually already talked to on our Group A Strep podcast, but we've asked her to come back again, because we liked her so much before, to talk about measles. Liz, would you like to introduce yourself?
Thanks, Emma. I'm Liz Whittaker. I'm a Paeds ID consultant in St Mary's Hospital in Paddington, and I'm also an academic working at Imperial College London, and I have an interest in all things infection and immune related, and apparently I'm becoming a bit of an expert in fever and a rash. Who knew?
The reason that we wanted to do this today is because everybody is getting very worried and excited about measles, and one of the problems is that because the vaccine is so effective for so long, people aren't used to seeing it, they don't have much knowledge about it, and we seem to have lost that kind of knowledge about what measles is, how serious it is, how infectious it is, and what to do about it. So we're just here to fill in those gaps today. So Liz, I'm just going to ask you some questions. The first thing I want to talk about is we had a really straightforward case. Our paediatric emergency department is always full of children with fevers and rashes. And the other week we had children with fevers and rashes, and one of them turned out to have measles. So my first question is, how can you tell if a child with a fever or a rash has measles or something that's not measles?
I think that's an excellent question. And the problem is it's probably not that obvious. They don't come in necessarily with a sign on their head. And the differential for a child with a fever and rash is obviously very broad. So somebody, I think Damien Rowland, a friend of ours, came up with a catchy phrase, which is fever, rash, and the 3 C's. And the 3 C's are coryza, cough, and conjunctivitis. Now, that also pretty much covers adenovirus and a few other things like that. So that's not necessarily going to be the most useful guideline. And so what really makes you think about measles is an epidemiological link. And the link there is usually that they're unvaccinated or possibly partially vaccinated, but usually unvaccinated, that they've had a contact with a known case of measles or another unvaccinated child with a similar illness, that they've travelled to a high-risk area, and that's Birmingham and the West Midlands at the moment, but could also be parts of Africa, Asia, or Eastern Europe, that they are in a nursery with lots of other children who have also had measles, so a known contact. And so these are your main questions that you want to ask to kind of make you think, right, I need to get this child out of the waiting room and into somewhere where they're not going to pass on very generously this very infectious virus.
Perfect. Thank you. And I think that the public have forgotten what measles is like as well. And so you, like I, we've worked abroad. Measles is a really nasty illness. It is not like chickenpox. It is not like a cold. And so children with measles, when you say they have fever and a rash and the 3 C's, it starts like a cold. They have really nasty, sore red eyes and this distinctive cough. But what's really obvious is they're much more unwell at this point than other children. Is there anything else?
And miserable. I
Yeah.
completely agree, Emma. I think these children are sick and miserable. And I know we use that word in the context of Kawasaki, which is another really important differential for these children and why they need careful assessment. But children with measles they feel utterly awful and they behave like they feel utterly awful. Whereas your average child with roseola or parvovirus or other kind of common fever and rash uh, patterns don't feel quite so unwell. And I guess the thing that discerns them then from perhaps scarlet fever is going to be the cough and the eyes. So the two of the C's may not be there in scarlet fever, but that's another important differential. And as Emma was outlining, there is a pattern in how this comes about in terms of 3 or 4 days of a cough and of a cold-like illness before developing a very distinctive pattern of rash, which parents may or may not be able to describe to you, starting behind the ears and the hairline, spreading to the face and the rest of the body, and then over 4 to 5 days becoming very confluent. They tend to just become red, particularly on the face, and then it spreads and clears down through the rest of the body. And they may have the magical Koplik spots that every paediatrician aspires to see before they finish their career. I've only seen them once because generally the patients present after they've gone, if we're honest. But if you see them, you should definitely take a picture and put it in your teaching portfolio. So the fever, rash, and 3 C's. And the 3 C's are coryza, cough, and conjunctivitis.
Brilliant. So we've said we've got this really sick, miserable, rashy child there with measles. And I guess the next question you're faced with is, when should you admit children? So what happens to children with measles? What are the criteria for admission? Because actually, in our case, the child wasn't that sick and we sent them to the safest place, which is back home.
And so most of these children will be managed in the community. So we say that 1 in 7 children will develop a complication, but a complication can be something like otitis media, which is probably the most common thing, or it can be more severe things like pneumonia, convulsions, encephalitis, and things like that. And so your usual red flags that you'd be looking for in the ED or in primary care or any setting are, tachypnea, fever that's lasting longer than you'd expect, lethargy, abnormal movements, poor oral intake are the reasons for admission as usual. And then the other thing just to be aware of is that younger children are more vulnerable. So we say the under 2s, but absolutely the under 1s, we would have a lower threshold for admitting. And I guess if there isn't a clear, you're not exactly sure what's going on, these children should have bloods. So not every child with fever and a rash needs bloods, but if you're thinking, could this be Kawasaki or is it measles? That would be a reasonable time to do some inflammatory markers, because generally with measles, they don't tend to have really high neutrophil counts and CRPs and low albumins like you would see in Kawasaki. And they tend to have quite low inflammatory markers, even though they're so unwell. And then the other thing that they can get is secondary bacterial infections. And that's the other reason that you might want to do bloods in a particularly unwell child, is just to make sure you're not missing something that needs antibiotics as part of the management.
Brilliant. Yeah, I absolutely agree. I think, people forget they can get diarrhea, they can get dehydrated, they might just need fluids. I think the other diagnostic conundrum is that children with measles get quite a high temperature and then they have a fit. And then your problem is this a febrile convulsion or do they have encephalitis? And that's another time.
Yeah.
You might want to admit them, you might want to do some tests, and then you're thinking about lumbar punctures, possibly doing some scans of their brain. And I think that people do get confused with the difference between acute encephalitis and SSPE. So I'm going to ask you to go through febrile convulsions, encephalitis, and SSPE, which is subacute sclerosing panencephalitis.
This is really difficult, isn't it? But this is what we do as paediatricians. The child in front of you has this snapshot here, and you have to make a decision about what you're going to do. And the safest thing may be to admit these children. And looking at admission rates in the UK, they are probably higher than need to be, but often with very short admissions. And I think that's because the safest thing to do may be to bring somebody in for 24 hours for observation. Because if this was a febrile convulsion, which is common in this age group between 6 months and 6 years, then obviously they bounce back and recover quite quickly and will have relatively normal bloods and won't be lethargic and encephalopathic in the recovery period. But if it is encephalitis, which we don't want to miss, because there may be specific treatments we want to give, or certainly they may end up becoming very unwell and ending up in intensive care, then being in hospital is the safest place if they have that onward progression. Subacute sclerosing panencephalitis, which we all know way more than we should given how uncommon it is, actually doesn't happen in the acute phase. This happens later down the line, and wouldn't be part of the acute illness. It happens and it is vaccine preventable. That's the thing that is so tragic about the low vaccine rate in children at the moment, and it occurs in about 1 in 10,000 people. And we've all learned how to recognise it on an EEG so that we can pass our membership exams. But I think actually we need clever neurologists to remind us of it when the child presents outside the context of a febrile illness.
What is the incidence of encephalitis, and how would you expect somebody to recognise encephalitis as opposed to ordinary seizure with a fever?
So encephalitis, so convulsions happen, as you said, relatively often in about 0.5%, and encephalitis we think is in about 1 in 250, or between 1 in 250 and 1 in 1,000. So it's relatively common, to be honest. I would say that was a relatively common for an infection. It's just the infection is rare in our setting. And children with encephalitis may or may not have seizures, which may or may not be focal or generalized, but their level of consciousness is subdued. And so they would be often very lethargic. And I think you do need to remember that lethargy can be a symptom of encephalitis. I think people will be like, oh, they're just sleeping a lot. And I'm like, that's not normal. Children should be waking up to feed, and they may sleep more than usual when they're unwell, but they should wake up and be completely normal in between. And so I think it's really important to be able to make that assessment. I think parents struggle with that sometimes, but you as a health professional should be able to tell that they're not waking up, sitting up, having a drink, being appropriately interactive. And then that's when we'd worry about encephalitis.
But for me, that is actually quite a common complication. And this, for me, is one of the reasons that I would really want my child immunised, because I think this is actually much more common than in ordinary viruses that we see in the community. All right.
Absolutely. And we know encephalitis, can have long-lasting impacts. And they may be severe. So these children may develop seizure disorders or other obvious neurology, but they can also be subtle in terms of neurodevelopmental and behavioral and learning difficulty impacts. And so I think people, worry about the acute phase, but it's the long-term impact that's really devastating.
Absolutely. So we've talked about the child who came to the emergency department, our criteria for admitting them, some of the complications, but we haven't really talked about how we definitively know if this child has measles or not. So let's talk a bit about investigations. This is all about what you spit on, isn't it?
Yes, I think actually it's so confusing because a lot of the national guidance talks about the health protection team sending oral fluid swabs, which they do. But most of that guidance isn't actually for a hospital setting. So if you have a patient in front of you in hospital, and particularly if you're admitting them, then you need to send a diagnostic test through your hospital laboratory. And that will usually be an oral fluid test. So it's great. You don't have to try and aim for the tonsils. They can just suck on a swab, and it needs to go into viral fluid medium. And that will vary depending on where you work, but it's really good to go and find out what that is. I can't tell you what every hospital does. Some hospitals are doing in-house testing. Most hospitals are sending it to an external lab for testing. So the turnaround isn't actually as rapid as it might be, for example, for a rapid test for flu or RSV. And so you will often have to manage this on suspicion whilst you wait for that diagnostic test. I think even if you're sending them home, it is helpful for the health protection team if you can send a diagnostic test before they go, because otherwise they post out a sample to the family who then have to post it back. And we know that that's an unreliable system, so they don't get full surveillance data. So just even from a surveillance perspective and then contact tracing, it's really helpful if you don't mind doing that. Thank you. So that oral fluid test is usually for PCR for the measles virus. So it's a molecular diagnostic test looking for the genetic material of measles. They will also often do oral serology for IgM and IgG, which is less specific, but a very high IgM sometimes comes back quicker than the PCR and can also be really helpful from a diagnostic perspective. Sorry.
Fantastic. And I think you've got to remember this is a child with a rash, and often it's not as obvious as it sounds like when we're talking. So really what you're going to be doing is taking some swabs, and you're going to be looking for flu, adenovirus, RSV, maybe you'll do your normal viral panel, and then you'll do this extra swab for measles, and you might be doing some blood tests, and those would be standard, routine, full blood counts, renal and liver function, and you might also be thinking about streptococcus, so you might be doing a bacterial swab for that, or thinking about an ASOT. So at this point, it's just remembering that measles is around and you need to add in an extra swab.
Exactly. And I guess the other thing to be aware of in a very sick young infant, if you're not sure, do call your regional paeds ID team. We love chatting about children like this to give you advice and support if you're unclear. And actually, the list of investigations on your Kawasaki guideline will cover most of the things that we would like you to send as a quick turning point if you're in A&E looking for something quickly.
Oh yes, it's brilliant. I often use that. So we've talked about this child, and our child wasn't very sick. And we know that in most cases, viral infections get themselves better. But should we talk about what we can do to look after or treat children with measles?
Yeah, and it is actually mostly supportive care. So you've mentioned diarrhea, really, really common to get diarrhea in measles. And so input, output weights, fluid management, the usual things that you would do for that, making sure they're not tachycardic, etc. NG fluids are always a preference for me, but that will vary from site to site if you can do it. And managing their fever, and then looking for secondary bacterial infections and giving antibiotics as appropriate. In terms of specific treatments, we don't have great antivirals for this. You will hear people talk about ribavirin. We wouldn't recommend this routinely for patients with measles. And the other thing to be aware of is people who, particularly if you've worked overseas, like Emma and I have, you may have doled out vitamin A to children in a measles outbreak in another setting. That's actually not appropriate in our setting because the children in a refugee camp, for example, have other risk factors for severe disease, including malnutrition and vitamin deficiencies. And so that's when vitamin A has been shown to have a proven benefit. There may be some children who are severely unwell in an intensive care or in a hospital for whom vitamin A is appropriate. But for most children with measles, we aren't recommending the use of vitamin A. And then finally, for patients who are immunocompromised, there may be a role for intravenous immunoglobulin, but this would obviously be on a case-by-case discussion with your virologist and paeds ID teams and pharmacy.
Perfect. So it's management like usual, no extra vitamins, but obviously we're always promoting everybody to have a healthy diet. And vitamins, I would say vitamins are better taken in vegetables rather than pill form. And just being aware, you know what to look out for if they deteriorate. So remember, if you're sending children home, be very clear with parents, give them good safety netting, make sure they know where and when to come back. There's always information on Healthier Together, which is the website, which is now almost national and has a centre in London. So you can text parents direct advice about measles and about fever. So our patient was well, we gave them straightforward advice, we sent them home, but they got their measles from somewhere and they're going to give it to somebody else. So we have to think about contacts. So what kind of advice, what do we need to do at that point where we think we have a suspected measles case? Because we might not have it confirmed at that point.
Yep. So did you know that 90% of unvaccinated contacts will get infected? Measles is so infectious. And a contact is pretty much anybody. So it's anybody in the household, anybody you've had face-to-face contact with, and anybody who was in the room with you for 15 minutes or more. So that's a really low threshold for calling them a contact. This is a very infectious virus. But the most important thing, whether you're admitting the patient or sending them home, is to ascertain whether there's anybody who's highly vulnerable at home. And that would include pregnant people, infants under 1 year who are both at risk of severe disease and are likely to be unvaccinated, and then anybody who's immunocompromised. And so we'd really suggest that you ask families who there is in their household and who they've spent time with who might fall into those categories. And the good news is we're not expecting you to do any contact tracing. It's just that you can then highlight that to the health protection team, because if they're in the middle of an outbreak, they may get lots of referrals. And if you let them know there's a high-risk person, they can prioritise that family.
So if I'm sitting in a GP practice and I see somebody, I think this child might have measles, but they're relatively well, I would do a swab, an oral swab. I would give them some general advice about fevers, and then I would have to do some contact tracing, or better still, I could contact the Health Protection Agency. So how would I do that, Liz?
So the health protection team are unique to your locality. So there isn't one number for the country, but if you Google Health Protection Team UK HSA, you will get a little box which says put your postcode in here, and it will tell you how to contact your health protection team. At the moment, we're asking everyone to phone the health protection team because the numbers are not so high at the minute. And just to be clear, there is an outbreak, but it's not terrible. So it is manageable. If things get busier, it will probably become an email contact for the health protection team. But when you put your postcode in, they will know how busy their team is and will give you the appropriate recommendation to contact them, including a direct number.
Fantastic.
When you call, go on.
So you don't actually have to do anything other than ring this number and they will do it for you.
Yes, but you will make an immediate friend if you have the information to hand that they are going to want to know. So it's probably worth gathering that together before you call them. You will initially probably speak to an admin operator rather than an actual health protection doctor, who will take details including the name and address and contact details for the family, and what your suspicious disease is, because they obviously take notifications for lots of things. But if you can then tell them who's in the household that you're worried about, so there's a pregnant lady who's 39 weeks, or there's somebody who's been on chemotherapy for 6 months, or there's twins under 1, then actually that's really helpful for them in terms of prioritising their workload.
Amazing. That's great. So in our case, we had to do contact tracing for the whole of the emergency department. So all the people who were sitting in the room with a child with a fever and a rash. And so this brings us on to a really interesting discussion. So in our waiting room, we had obviously 5 children under 1. We had some children who were waiting to have treatment, who were having treatment for leukemia and had come in with a fever. And we had staff members who were older, who hadn't been vaccinated. So, Liz, let's think about what happens to all those contacts and what they need to have to keep them safe and stop them catching measles.
So this is, I'm a nerd, so I love this. This is my type of thing. It's like some kind of weird PACES exam question where I get very excited. So we know the highest risk groups are pregnant women because they're at high risk of severe disease, but also stillbirth and premature labour. We know that under 1s are at high risk of severe disease, so complications such as the encephalitis we mentioned are more common in that age group, and they haven't been offered a vaccine yet, so are more susceptible. And then immunocompromised I'll come to in a minute because it's a bit more complicated. So for pregnant women, you don't need to do anything in a hospital setting, but the health protection team will arrange for them to have human normal immunoglobulin in the community to boost their immune system. Actually, what they'll probably do first is get their booking bloods checked to see if they have IgG, because sometimes people think they haven't been vaccinated and they have, and you have a few days to sort this out. So that's what they will actually do. For a child under 1, if they're under 6 months, we just give them human immunoglobulin. If they're 6 to 9 months, it depends on the level of contact. They may either get human immunoglobulin, or if it's not a very close contact, we'd offer them a very early MMR. And if they're between 9 months and a year, we give them an MMR. I don't expect you to remember that. It's on page 49 of the national guidelines if you want to go and have a look for reference. But the key thing to know is that if they get an MMR under a year of age, it doesn't count. And the reason for this is, I think, quite interesting, and it's the reason why we designed our vaccine schedule, is because there may be maternal immunoglobulin around and the vaccine might not take properly. So we would assume that vaccine has some benefit at that time as part of the protection, but we would want them to still have 2 doses at the normal time that vaccines are offered. That's just the really key learning point there.
So if you're thinking about contacts, pregnant women will have human immunoglobulin in the community. Children under 1, you need to think about whether they need treatment, but particularly under 6 months. So they might get immunoglobulin under 6 months. The older ones might get an early MMR, which is a bonus MMR, and they still carry on with their normal vaccination schedule. And now we've got to the tricky ones. So what about the child who is having leukemia treatment, who's come in because they've got a fever?
This is really interesting because humoral immunity, or your antibodies, are actually the protective mechanism here. So things that you might have learned in terms of protection for other things are different when it comes to this immunocompromise. And there's 2 groups, Group A, who might still have antibody and therefore you don't need to worry about, and Group B, who don't have antibody and you have to worry about. Group B all get IVIG or immunoglobulin, and that will be given in a hospital setting, and through the specialist teams in pharmacy, and the health protection would call the paediatric team to arrange that. For Group A, then you do talk to the health protection team and do a risk assessment with them. So this responsibility doesn't lie with you, but you may be involved in a conversation or a discussion about it. And so any child who has leukemia or nephrotic syndrome on steroids, or has had a transplant in the last year, or any kind of immune modulatory therapy, it's best to check. Many of them may not need any post-exposure prophylaxis, but we don't want to miss the ones that do.
Yes, and I think it's really interesting because they're a really big group now. So you have to think about all the children on monoclonal therapy, children with severe inflammatory bowel disease, all the children with things like juvenile idiopathic arthritis. So I think the key point here is what you said earlier, is take a good history, make sure you've identified them, and then get advice from your paediatric infectious disease team or the HPSA.
Yeah. So the other thing to know, though, is that the child who had 2 per kilo of pred for their asthma for 3 days doesn't fall into that immunosuppressive category. You have to have a reasonable amount of immunomodulatory therapy to be at risk. And so that kind of, or DEX for their creep, those are children that we wouldn't really worry about. If they were unvaccinated in a contact, we'd probably just give them an MMR. But it's anybody beyond that that would be of a worry.
Yes, that's one of those questions that we get all the time. So short courses of prednisolone, that's like less than a week, or one-off courses of dexamethasone for croup, they do not count as immunosuppressive therapy. We've decided, we've rung the Health Protection Agency, we've sorted out the pregnant ladies, the babies, and the immunocompromised children sitting in our emergency department. But Liz, what about all the staff? Because they were going in and out of the same room where the child with measles have. So what happens to staff?
Yeah, this is something that I think worries a lot of people, because particularly for the more mature members of staff who might predate the introduction of measles vaccine, or in particular the non-normal healthcare staff. So if you're a receptionist or an admin person, you might have a different occupational health pathway. So I don't know if you know, but your measles serology was likely to have been checked when you started work with occupational health. And so you should be able to access that. That should be universal, but I know that sometimes things are missed. And there was a really nice table in the National Measles Guideline, which has the years that vaccines were introduced, and when we think people would have had natural immunity from infection in it. So I had a single measles vaccine. You can try and guess my age from that. I didn't get an MMR. I got rubella when I was an older teenager. And the other question that comes up on this is, if I know my rubella status, does that mean I'm definitely protected from measles? And the answer to that is no, because we used to give the the rubella vaccine separately from measles. So most healthcare staff should know their status. The safest thing to do if you're not sure is just to have a dose of the MMR. It's a live attenuated virus vaccine. Sorry, the safest thing to do if you're not sure is to just have a dose of the MMR. It's a live attenuated vaccine, and if you have immunity, your immune system will just wipe it out. If you don't have immunity, it will give you immunity. And it's really beneficial to have it. And so, generally speaking, if you're not sure, that's the thing to do. But most people should have access to their information. And if you have someone who you know is not protected through choice or circumstance, then they should not be looking after these children, and they should be kept away from them where possible and encouraged to do what they can to protect themselves, including PPE.
Thank you, Liz. Yes. Originally, you got a measles vaccine, then you got measles rubella, and then eventually MMR. And I may have been in that category. We actually had somebody who actually remembers measles and getting measles. So we have got people older than me, but only just.
Yeah.
And we did exactly what you said. And our occupational health team came down and gave everybody vaccinations, both at the time and opportunistically afterwards. So I've just had my MMR very recently.
Oh, wow.
I felt quite ill. I had lots of aches and pains, exactly as you expect, but I won't get measles. But I think the other thing that you alluded to, which is really important, is being really careful and protecting yourself from measles. So about PPE and the need to have fit testing and wear masks, which seems to have completely gone out of fashion now. But I always wear a mask because when I'm in the emergency department, I am constantly seeing children with fever, rash, and cough. And I have no idea what they have at the time I see them. So what are your thoughts on this?
I don't want to get a cold, so I'm happy to wear a mask around infectious children. And I also don't want to get anything more serious. So I didn't find the trend of wearing masks that onerous personally. However, just to be clear, the national guidance for PPE for measles is to wear an FFP3 with eye protection, a gown, and gloves. And this may seem over the top when you know that you're vaccinated, but it has two roles. One is to protect you just in case your vaccine didn't work. It's very unlikely, but you don't want to get sick. Also, it might have something else, which is worse. So it's always good to be overprotected rather than underprotected. And then finally, you might still get a very mild version of measles and then become infectious and then continue the onward transmission of this outbreak. And so the main role that you have as a paediatrician is to try and break transmission. And that is either through early identification and isolation, so preventing all those people in the waiting room being exposed, by picking up the child that you can prevent from becoming unwell through the post-exposure prophylaxis, but also by not becoming part of the entire transmission cycle yourself by wearing PPE.
And we always have to mention, try and use tissues, throw them away, cough on your arm, and wash your hands. I can't say this often enough. And you've got another hot tip for preventing measles or screening it early, don't you?
Yeah, so what we're suggesting, and I'm very unpopular with some people for suggesting this, is that we are really just on it in terms of those children and getting them into the side room quickly so that Emma and her colleagues don't have to phone 29 families who were in the waiting room and were exposed. So I'm not suggesting that every child with a fever and a rash has to go into a side room. That's just completely impractical. However, if you have a poster up signposting parents to things that they might want to consider, including, is your child vaccinated? Have you travelled to an area where there's lots of measles? And if you ask your triage staff or your reception staff to just ask those questions of children who present with a fever and a rash, how are they vaccinated or have they been in contact with someone with measles, you might be able to swiftly get them out of the waiting area and prevent having to do that extended contact tracing exercise. And it's a really simple thing to do. It's 2 extra questions for your reception staff and a poster, and it might just save a lot of time and effort and potentially a severely unwell immunocompromised person.
We probably should have asked this at the beginning, but I guess we just got into the clinical side of it very quickly. But why is there so much measles around now? What's happened to change things, Liz?
So this is a really interesting story. There have been measles outbreaks in the last 10 years, so in 2013 and in 2019. And then there have been a rise in cases over the last year because of global outbreaks in Asia and Africa, and because of poor vaccine coverage, which started in the pandemic and has kind of continued. And so in the UK, our vaccine coverage just isn't as good as we'd like it to be. And so the dose uptake in 2-year-olds for the first dose is 89%. And we really need that to be 95%. And for 2 doses, it's at 85%. And actually, where I work in London, it's as low as 60% in some areas. And this is a real worry, to be honest. And the reasons for that are multifactorial. There are a subgroup of people who are still concerned about autism in the MMR, which is probably the most over-investigated outcome of any vaccine that's ever been looked at. And I can confidently, hand on heart, say that hundreds of thousands of children have been analyse the data from hundreds of thousands of children and show that there isn't a link with autism. But actually, it's more than that. There's a convenience and an access issue for many families, and particularly for that second dose, where it can be really tricky to get out of your 0 hours contract on a Thursday afternoon, which is the only time your GP practice offers it. There may be a language barrier. There may be a cultural barrier. So for some groups, it's just not acceptable within their communities. There are worries about pork in the MMR vaccine, and we have a really great pork-free MMR vaccine called Paediatrics, which is available in most areas to make sure that people are aware they can get a pork-free vaccine. And then the final thing is that, all of the negativity about COVID vaccines has just shaken people's confidence in any vaccines. And so they're just all a little bit worried about vaccines in general. And I think we have a role as paediatricians to know a lot about vaccines so that we can confidently talk about them with patients and not judge them if they're not vaccinated. There are many reasons why people don't get vaccinated. And usually if you just say, what is it you're specifically worried about? Can I point you to a really good resource like the NHS website or the Oxford Vaccine Group website? Many families go and read them and are quite happy to take the vaccines. They just needed somebody they trusted to be positive about them and to give them accurate information rather than whatever nonsense is on TikTok and Instagram, etc.
I think it is a number of reasons that are really important. So there was a slip in vaccination rates during the COVID pandemic because people just couldn't get that. And we haven't really caught that up. There is immigration from areas where there is less vaccination. So we see a lot of people from Eastern Europe, or, for example, from Russia or Ukraine, who just can't get hold of vaccines. And there is still some hesitancy about using vaccines, although, as you say, there's very, very clear evidence that there is no link to autism.
Yeah. And so one of the things that, if you're interested in a QI project or something like that, that you could explore is whether there's any opportunity to do opportunistic vaccines where you work. So UKHSA have a catchy MECC, which is Make Every Encounter Count. And the idea there is that every time you see a patient, you check if they're vaccinated, and if not, either offer to vaccinate them or signpost them to where they can get a vaccine easily. But we should be trying to do what we can, particularly in areas where vaccine coverage is low, such as London and the West Midlands, to make sure that we're catching as many people, whether in front of us, as we can.
Yeah, actually, in the Northeast, the vaccine level is really good for the first MMR, but not quite so good for the second dose. But it is better than in other areas, which is one thing that we can be happy about. But I agree with you.
Together advertising, Emma.
Yeah. But opportunistic vaccination doesn't need to be difficult. So often if you see somebody on the ward, just before they're about to discharge them, you can offer them vaccines. If they're coming to clinic for another reason and you happen to notice they don't have vaccines, that's another opportunity. And I think it's really important to think about going out to reach hard to reach communities. So we're doing some really interesting work with the food banks and schools. So I think that you need to look at your area and know what's happening in your area and how you can ensure that everybody gets the opportunity to be immunised, because it's a lifesaver, literally.
This podcast is a collaboration between Medisense Medical Education and the Royal College of Paediatrics and Child Health. You can find more creative learning resources on www.medisense.org.uk, and of course a wealth of information on the important work of RCPCH on rcpch.ac.uk or #ChoosePaediatrics.
The views, thoughts and opinions expressed in this podcast relate solely to the speaker and not necessarily to their employer, organisation, the Royal College of Paediatrics and Child Health, or any other group or individual.